Thank you for taking the time to watch our Mental Health 2 oral presentation. The following presentation was put together by Brittany Knox, Sadie Stover, Mo Nelson, and Kyle Kramer. The following presentation is in regards to a patient who is a 62-year-old male who presented to the emergency department at Mercy Claremont because of an intentional overdose of gabapentin. The patient has been addicted to methamphetamines for over 40 years and feels he has lost everything that is valuable to him. The patient was admitted with suicidal ideation but currently denies suicidal or homicidal thoughts, and the patient is not experiencing any current delusions or hallucinations.
Before diving into subjective and objective data, we thought it was important to first review the differences between the two.
When we talk about objective versus subjective data, what we're doing is we're talking about how we assess our patient. Okay, so we need to understand the difference between objective data and subjective data. First of all, when we talk about objective data, we're talking about things that we can see. Okay, we're talking about our five senses. Can we hear it? Can we see it? Can we taste it? Hopefully we're not tasting it if we're talking about nursing care. These are things that we can see with our five senses. So with these types of things, we're talking about our vital signs, respirations, blood pressure, heart rate. We might be talking about a wound appearance. We might be talking about how the patient ambulates. Things that we can actually physically see on a monitor, on our patient. That's objective data, things that we can observe. Now, where we can get a bit confused is when we talk about subjective data. Subjective data, we gather it from what the patient tells us. Does the subject tell us something? If the subject, being the patient, tells us something, then that's subjective data. We can't gather it from our own personal five senses. So what a lot of nurses and nursing students do is they get in trouble in thinking that pain is objective, where pain is actually a subjective data point. Now the patient is telling us what their pain is, so the subject is telling us their pain. It's not one of our five senses. That makes it subjective data. So when you're making out your nursing assessment or when you're answering a question, ask yourself, is this something that I can sense with one of my five senses? If I can't, it's subjective data. Is this something the patient tells me? Is this a feeling? Is this pain? Is this what the patient is telling me about themselves? That would make it subjective data. Can we verify the information with a monitor, with our eyes, with our ears? Then it's objective. So objective data, we can see it, we can feel it, we can taste it, five senses. That was 10. Subjective data, that's something that the patient tells us about themselves. The subject is telling us. Objective, five senses. Subjective, subject is telling us. That's what you need to know from it. It's really that simple.
The following information is subjective data collected from an interview with the patient. The patient had a kidney transplant a few years ago. He has needle remnants stuck in his left arm from IV drug use. He has a pacemaker. He's been gaining weight since withdrawal from methamphetamines. He has a history of binge drinking and no family history of mental illness. The patient was sober in the 80s. He religiously attended AA meetings, and he was a sponsor for 5 men throughout the years that he was sober. And the patient reports that his quote-unquote insanity began once he moved to Lebanon, Ohio, and it was because he didn't know anyone and he met and became close with the wrong people. The patient has medical diagnoses of osteoporosis, arthritis, COPD, hypertension, and cellulitis. And the patient has a psychiatric history of major depressive disorder, substance abuse of methamphetamines, and suicidal ideation. A head-to-toe assessment was conducted on the patient, and the following information is the results from the head-to-toe. The patient is farsighted, wears glasses, wears hearing aids in both ears, and has no recent change in smell, taste, hearing, or nasal congestion. The patient's respiratory function, his lung sounds were heard in all lung fields. His breath sounds were even and clear, symmetrical expansion of his chest, and his respirations were unlabored. He has no chest pain. He has a regular and strong radial pulse, but the patient did have hypertension. The patient's last bowel movement was October 21st. He has no abdominal pain, no tenderness or guarding, and his abdomen was soft and round. The patient had complete range of motion of all extremities. He had a normal gait and it was experiencing no weakness. The patient's skin, he had purple discoloration on his left arm. His skin was warm to the touch and he had no pallor or cyanosis. The patient had strong pedal and radial pulses. His skin was warm to the touch. His capillary refill was less than 3 seconds. The patient had no changes in urination or increase in thirst. The patient did have tremors and was experiencing anxiety. The pathophysiology of addiction involves a combination of neurotransmitters that are associated with the pleasurable sensations that a person feels with the substance and memory of the substance. The brain actually changes structure and the neurochemistry changes when developing an addiction. The neurotransmitters involved are dopamine, which regulates the movement and coordination, emotions, and voluntary decision-making ability. It activates the neural pathways that sense pleasure and reward and aid in the memory that triggers the desire for repeated use of the drug.
What are your fiercest cravings? Whether we're ducking out for a smoke, going for glory at the blackjack table, or drowning our sorrows in a glass of wine, we all have ways that we seek to push our pleasure buttons. But what happens when this need for pleasure becomes a full-time pursuit? When our fix turns into something more like a dependence? Used to be that addiction was considered a sort of moral failing. But now, with a much better understanding of how the human brain works, scientists are learning new clues about the vicious cycle of desire, binging, and withdrawal that traps tens of millions of people. Our brains evolved a reward system based on a chemical called dopamine. This amazing neurotransmitter creates cravings in us to encourage behaviors that help us survive, such as eating, procreating, or interacting socially. In turn, pleasure is then stimulated by other neurotransmitters in hedonic hotspots of the brain. When dopamine's craving circuitry overwhelms the pleasure hotspots, addiction occurs. Essentially, your reward system is hijacked. Let's break it down this way. Your desires are triggered when dopamine, starting at the top of the brainstem, travels through neural pathways to affect the brain. Drugs increase this flow of dopamine. Where does the dopamine go? It flows throughout the brain's craving circuit, including the dorsal striatum, where brain nerve cells called neurons begin to form habits by IDing fun things that you've done, like buying drugs or cigarettes. Dopamine also goes to the prefrontal cortex, where with the help of an amino acid called glutamate, rich visualizations that cue cravings are conjured. Think images of drug paraphernalia, sex, or a bottle of booze. Then there's the amygdala, where the dopamine causes neurons here to be stimulated by learned emotional responses, like rich, pleasure-coded memories. So what happens when drugs artificially flood these pathways with dopamine? For one thing, the rush can rewire your brain to want more drugs, and thus create addiction. But it turns out different drugs interact with the reward system in unique and interesting ways. Cocaine, for example, blocks dopamine transporters and prevents the removal of excess dopamine from synapses. Methamphetamine, on the other hand, floods the terminals of neurons, displacing dopamine into synapses instead.
So now we're going to discuss the pathophysiology of depression, specifically major depressive disorder. Our patient has discussed how he has felt feelings of depression his entire life, and lately those feelings have just started to get stronger and stronger, and he has been diagnosed with major depressive disorder. So the underlying pathophysiology of depression is not entirely understood. However, research has shown that disturbances in the neurotransmitters of the central nervous system, or the CNS, such as serotonin, norepinephrine, and dopamine, certainly do appear to have an effect. So as we know, many medications and other drugs can have an effect on these neurotransmitters, whether there's high levels or low levels. So I think it would be really interesting to maybe do some tests on our patient and see what his serotonin levels are, what his norepinephrine levels are, and dopamine levels are, just to kind of get an understanding as to whether or not that's having an effect. So while those levels of neurotransmitters are, and their relationship to depression may not entirely be understood, studies have shown that they are able to produce depressive symptoms in research subjects when there is a reduction in serotonin levels within the central nervous system. So I think if we were to look at our patient, he would certainly have lower levels of serotonin in his brain than, maybe someone who does not suffer from depression. So moving on, neuroimaging has also been used to show that depression is associated with decreased metabolic activity in the neocortex of the brain and increased activity in the limbic system. So I think this would be really interesting if we were to get an image of our patient's brain and maybe just see, maybe look at that neocortex of the brain and see if there is decreased metabolic activity there. And then right along with that, if we were to go a little deeper, using many of these images, researchers have found that an area of the prefrontal cortex has abnormally diminished activity in people with depression compared to those number of people that do not suffer from depression. So I think once again, this would be really interesting if we were to, go in and maybe get an image of this brain and just look at that prefrontal cortex and maybe see that there's increasingly diminished activity in that area of the brain within our patient. So while this does not appear to fall right in line with previous studies, considering the prefrontal cortex area has connections with areas that regulate dopamine, norepinephrine, and serotonin levels within a person's brain. So once again, this goes right along with the neurotransmitters. Maybe there's low levels of, serotonin, and this is the area of the brain that, certainly regulates those parts. So I think, once again, it'd be really interesting to go in and see the images of the brain and, maybe just the diminished activity within it and, really look at that prefrontal cortex. And then finally, so endocrine changes have also been shown to be related to depression, such as menopause in women and low levels of testosterone in men. So once again, I think it would be really interesting to look at our patient, maybe see whether or not there are low levels of testosterone or something to that extent. So again, that's overall the pathophysiology of depression. It's not entirely understood, but there is, I think, definitely a link between the neurotransmitters in the brain and feelings of depression.
Neuroimaging studies reveal that many brain circuits that normally regulate mood are dysregulated in depression. Located deep within the brain, the amygdala processes highly salient stimuli such as rewards and potential threats. In depression, the amygdala is overactive and responds excessively to negative events. In turn, the amygdala connects to a set of brain regions that hone the physiological and behavioral response to emotional stimuli. These areas include the medial prefrontal cortex, the nucleus accumbens, the hippocampus, and the insula. The hippocampus is involved in memory formation, and along with the prefrontal cortex, is particularly vulnerable to the effects of stress. Depressed people are more susceptible to stress, which can cause physical changes in the brain, including atrophy of the hippocampus. This and other changes in depressed people may cause inappropriate responses to emotional events. The medial prefrontal cortex is involved in regulating how strongly we react to emotional stimuli. Treatments such as antidepressant drugs, cognitive behavioral therapy, and electroconvulsive therapy affect the structure and function of these and other brain regions.
Now that the patient's medical and psychiatric history, diagnosis, and pathophysiology have been discussed, pharmacology can be discussed as it relates to the patient and the patient's ailments. The patient has been prescribed the following medications: Keflex, Klonopin, Cymbalta, Bactroban, Nicoderm CQ, Protonix, Primidone, Inderol, Simvastatin, and sulfamethoxazole trimethoprim. Of these, Klonopin and Cymbalta constitute the patient's psychopharmacology. Let's now discuss each of the medications in greater detail.